Assalamu alaikum wa rahmatullahi wa barakatuh. Hi everyone, welcome to a new session from a film reading session and lectures. And as usual, we discuss some interesting cases. And as usual, we start with a neuro case. And this is a 17 years old boy who came complaining of epilepsy. This is the T2 weighted images, and this is T1 weighted images. Let's compare the flare with the T2 weighted images. In epilepsy, it is important to look for the temporal lobe. In coronal images, it is important to look for the any lesion or abnormal signal compressing the hippocampus or affecting the temporal lobe. We should compare both sides to show if there is asymmetry in the hippocampus, asymmetry in the temporal horn of the lateral ventricle, if there is an area of abnormal signal in temporal lobe, if there is a space occupying lesion. This is the most important thing in a case of epilepsy. You should look for the temporal lobe. As much as important the looking for the temporal lobe, it is important also to look for the cortices, the cerebral cortices, because there is a lesion that is commonly affect the cerebral cortices and cause an epilepsy, and this is one of the commonest cause in of epilepsy, which is called focal cortical dysplasia. In this patient, if we scan this MRI brain, this is the T2 and this is the flare in these axial images, we can clearly see here that there is an area of abnormal signal that is affecting the cortical and subcortical region in the left frontal lobe. This area of cortical and abnormal and cortical and subcortical abnormality, it exhibiting high flare and high T2 weighted images, and also it is associated with an ill definition of the gray-white matter interface. So in such lesions, that in such a location, it is in the presence of the clinical history of epilepsy, we should consider focal cortical dysplasia. In the diffusion weighted images, this lesion or this area of abnormal signal show no definite diffusion restriction. This is the ADC value. It is high in the ADC value, no evidence of elevation in the diffusion, so it is a free diffusion. There is no diffusion restriction. And in the post-contrast images, we can see that the lesion is here. This is the lesion is show no evidence of enhancement. So the lesion is cortical and subcortical. The lesion is show no diffusion restriction. The lesion is showing no evidence of enhancement. Actually, in this setting, the focal cortical dysplasia is on the top of the diagnostic possibility. However, there is an important differential diagnosis which should be considered and should be try to differentiate between both entities. The other differential diagnosis is the low-grade glioma. The low-grade glioma is usually similar to the focal cortical dysplasia, and it is usually hard to differentiate or difficult to differentiate between both entities. So to differentiate between both entities, we can rely upon the certain criteria or the following criteria. Number one, in this case, there is affection to the cortical gray matter, but there is no swollen or expansion of the cortex. The cortex here is involved, yes, but the cortex is not expanded. And expansion, one of the criteria and important criteria that is goes with a low-grade glioma. Usually the low-grade glioma, when affect the cortex, it usually cause expansion or enlargement of the cortices. So here it is not present. So this matching or goes with the low grade glioma. Sorry, with a focal cortical dysplasia. There is absence of the expansion. So this with focal cortical dysplasia. This is number one. Number two is the affection of the gray-white matter interface and the ill definition. The ill definition of the gray-white interface, one of the important sign in the focal cortical dysplasia. It is best appreciated in the axial images as we see here. We can see that there is an ill definition of the gray-white matter interface in the region of the lesion. This is the region of the lesion. We in this normal area we can see that this is the gray matter and this is white matter, and there is a sharp definition between the gray-white matter interface. In this region there is an ill definition of the gray-white matter interface. We can't say, we can't determine where is the white matter and where is the gray matter. So this is an ill definition of the gray-white matter interface. Again, one of the criteria and one of the features that goes with focal cortical dysplasia rather than low-grade glioma. The third point is the age of the patient. Usually, the focal cortical dysplasia affect the patient age, younger patient age. As in this case, this is a 16 or 17 years old boy. So this is usually matching with the focal cortical dysplasia. The last sign that is present, that is not present here, is the transmental sign, which is a band that extends from the lesion to the ventricular system. And if you see this, it is a pathognomonic for the focal cortical dysplasia. This sign is actually a good positive sign, but its sensitivity is not so good. So it is not usually present in the focal cortical dysplasia, but once you see it, it is you should consider focal cortical dysplasia, not low-grade glioma. So all features here are keeping with that this lesion is a focal cortical dysplasia, not low-grade glioma. If we need further investigation to make sure that the lesion is a focal cortical dysplasia rather than glioma, or to differentiate between both entities, we can do MR spectroscopy, searching for the Colline peak. In the glioma, the Colline peak is usually elevated, while in the focal cortical dysplasia there is no elevation of the Colline peak. So these are the main points for differentiation between the low-grade glioma and focal cortical dysplasia. And as I said before, the differentiation between both entities is usually difficult. But in this case, we in favor with the focal cortical dysplasia rather than low-grade glioma. Okay, this is a 35 years old patient who came for emergency with signs of acute ischemia in the form of acute dysarthria and acute right-sided hemiparesis. In this case, it is important to searching for the signs of acute ischemia in CT brain. When you are facing such case with no other modalities, as we know, the best modality in the ischemia is the MRI. But if you facing such case with no availability of the MRI and the only available machine is the CT brain, you should searching for the signs of acute ischemia in the CT brain. This is the non-contrast CT brain of this patient. We can clearly see that the internal carotid artery in the left side is relatively hyperdense to the right side. And if we go upward again, this is appear that the origin of the internal carotid, the middle cerebral artery also is, or the terminal portion of the internal carotid artery is relatively hyperdense to the contralateral side, and the middle cerebral artery also is relatively hyperdense. This is called an MCA, or internal carotid artery hyperdense sign, and this indicate this usually one of the earliest sign in acute ischemia that is seen in the CT brain, non-contrast CT brain. Also, we can see here that there is an, if we see here that there is an ill definition of the region of the basal ganglia. If we can see here, this is the basal this is the caudate, and this is the basal ganglia, head of caudate, and this is the basal ganglia. We can see here the basal ganglia clearly. We can see this is the basal ganglia region, but here we can't appreciate the basal ganglia region in the left side, and this is the called disappearance basal ganglia sign, and this is one of the earliest sign in also in acute ischemia in CT. These signs are usually non-specific or non-specific or non-sensitive actually, but we should looking for them if the availability is the only CT, and in the clinical practice there is signs and symptoms of acute ischemia. We should look for the hyperdense vessel sign, and we should look for the disappearance basal ganglia sign, and this the earliest sign of acute ischemia in the CT brain. This patient do follow up CT brain after a few days, and we can see here that there is a hypodensity in the basal ganglia and the region of the left cerebral hemisphere along the territory of the middle cerebral artery. So these signs, this is a well-established infarction. The signs we spoke before are these are the earliest sign before developing a hypodensity in the cerebral hemisphere, and we can, if we pick it early and the patient treated properly and immediately, we can save the patient. But as I said before, it is the best modality in the cases of acute ischemia is the MRI. Okay. Next case here, this is 3 days or 5 days years old newborn that is coming for urgent MRI for ultrasound, transcranial ultrasound was done for this patient, and it revealed hydrocephalus. So this is a T2, and this is the FLAIR images for axial images for this patient. We clearly see that there is a wide separation of the dilated ventricular system that is interposed in between this ventricular system by interhemispheric fissure cyst. This large interhemispheric fissure cyst is causing mass effect and displacing the cerebral hemisphere, and such appearance actually is a spotting for which called interhemispheric fissure cyst that is associated with the agenesis of the corpus callosum. If we want to be sure if there is an agenesis of the corpus callosum, we should look for the sagittal image. In this sagittal image, we can clearly see that there is the presence of the rostrum. The only part of the corpus callosum that is present is the rostrum and the geno of the corpus callosum, while the rest of the corpus callosum is agenetic or absent. So this is a case of partial agenesis of the corpus callosum associated with the interhemispheric fissure cyst. Actually, there are two types of interhemispheric fissure cyst. There are type 1 and type 2 interhemispheric fissure cyst. According to if the cyst here is freely communicating with the ventricular system, as in this case, this is type 1. If there is an internal septation, loculation, no free communication between the cyst and the ventricular system, this is considered type 2 interhemispheric fissure cyst. And this is important because it usually affects the management. If it is type 1, just put the drain in this cyst, and the patient is usually manage the patient properly. But if there is an internal septation, loculation, you should cut these septations before you put a drain. So this is a typical case for the corpus callosum agenesis with interhemispheric fissure cyst, type 1 interhemispheric fissure cyst. In the coronal images here, we can clearly see also that this is the only part of the corpus callosum that is present. Here there is no absence of the corpus callosum, and this is the interhemispheric fissure cyst that is freely communicating with the ventricular system and causing mass effect along with the cerebral mantle or the cerebral hemispheres. In the cases of the corpus callosum agenesis, which is one of the entity of commissural anomaly, we should comment upon the other commissural fiber if they are intact or not. So the other important commissural fiber is that is present is the anterior commissure and the hippocampal commissure. The anterior commissure usually appear as a central dot that is just anterior to the column of the fornix. So this is the column, this is the fornix, and this is the column of the fornix. This small dot is usually called anterior commissure. If we see here in the axial images, we can see here that it is the anterior commissure is usually anterior to the third ventricle. If this is the third ventricle, these fibers that is communicating both olfactory areas are called anterior commissure. So the anterior commissure here is intact. The other commissure is a hippocampal commissure, and the hippocampal commissure here is usually slightly distorted, and it is usually communicating the two crura of the fornices. This is the left crus of the fornix, and this is the right crus of the fornix. And here, this is the area of the hippocampal commissure. Actually, the area this hippocampal commissure is usually better to be appreciated in the sagittal image just below the splenium of the corpus callosum. But here, there is a distortion by the mass effect of the cyst, and we can trace it by following. This is the fornix, and this is the crushes of the fornices. So the area that communicate both crushes of the fornices are the hippocampal commissure. So in this patient, the only part of commissural fiber that is missing is the posterior aspect of the corpus callosum, while the anterior commissure and the hippocampal commissure is intact. And it is important to say this if there is only agenesis of the corpus callosum or it is associated with other commissural anomalies dysgenesis, commissural fiber dysgenesis, because the prognosis of this patient. Usually, if there is a multiple commissural fiber affection, usually the prognosis is more severe and more bad than the only the corpus callosum agenesis. If the patient have the three fibers or the three types of fiber are missing, this is called tricommissural dysgenesis or tricommissural anomaly. So this patient have a corpus callosum agenesis with an interhemispheric fissure cyst. Also, we can see that there is a area of pluming artifact here seen at the dependent portion of the cyst and the ventricular occipital horn of the right ventricle. And usually this is one of the presentation of the neonatal ischemia or ischemic insult that occur in the neonate, usually present with an interventricular hemorrhage. But we can discuss this in a separate entity after we will talk or we will illustrate the ischemic pediatric ischemic insult lecture in the next module inshallah. Okay. This case is an example, also example for the one of the emergency that cases that occur in the hospitals frequently. This is patient with a spinal trauma, fall from height, and comes with a spinal fracture. And it is important, as I said before, to determine the type of the fracture. It is very important actually. And we have a scheme to reach the proper and correct diagnosis for a type of fracture, spinal fracture. The scheme, the first step in the scheme is to look for the alignment. If there is, this is the 12 fracture, this is apparently this vertebrae is fractured. We should look for the alignment of this vertebrae in relation to the other vertebrae, and we can see there is no significant malalignment seen at the fractured vertebrae. So this is the first one. To can exclude the translation injury. So this is not a translation fracture or translation injury fracture. Okay. The second step is to look for the interspinous distance. If there is a widening of the interspinous distance, there is no widening of the interspinous distance in this case. Because if there is a widening of the interspinous distance compared to the rest of the interspinous distances, this is make the diagnosis of distraction fracture is the proper and correct diagnosis. So this is there is no widening or there is no increase in distance of the interspinous distance, so this is not a distraction fracture. The third step is to look for the fracture and affection to the posterior cortex. If there is an affection of the posterior cortex, this is important. The fracture here is involving the posterior cortex, as we see here, and in the axial images we can see that the fracture is extended to involve the posterior cortex. And this is important because if there is an affection like this in this case, the diagnosis will be burst fracture. So this is a typical example for D12 burst fracture. Actually, many of the radiologists, if they see this fracture, they called it a widget fracture, compression fracture, and this is not correct. And this is the importance of the scheme. If you follow the scheme properly, we can reach the correct diagnosis. This is the affection of the posterior cortex, and there is even a small retropulsion of the superior vertebral endoplate posteriorly. And again, this is one of the criteria of the burst fracture. In the axial images, we can see the comminution in these vertebrae. If we see here, this is a fracture, and this is a fracture. So there is a comminution of the fracture, and this is typical for burst fracture. This is not a compression fracture. So in this patient, they have a D12 burst fracture, not a compression fracture, with affection of the posterior cortex and minimal retropulsion, comminution of the vertebral body. And this is the scheme of the how to reach the correct diagnosis about the spinal fracture. Okay. Next case here is very important and very difficult actually. This is the patient who came with signs and symptoms of intestinal obstruction for CT abdomen and pelvis. If we can see here, there is evidence of multiple small bowel dilatation that is showing multiple air fluid level. Here there is a multiple dilatation of the bowel loops showing multiple air fluid level. So there is an evidence of small bowel obstruction. The large bowel is collapsed, so there is an evident small bowel obstruction. In these coronal images, we can clearly see that there is signs and symptoms of closed loop obstruction. We can see here that there is in the pelvis uh, there is an inversion or inverted U-shape appearance of the dilated bowel loops, and there is a convergence of the mesenteric vessels. The mesenteric vessels here is converted toward a certain point. So these features are typical for the closed loop obstruction. So this patient have a closed loop obstruction, and the underlying etiology of the closed loop obstruction is usually three main causes. Either the volvulus, and we can clearly exclude the volvulus by the searching for the whorl sign in the mesentery. There is no whorl sign in the mesentery, so this is not a volvulus. The second main cause also the adhesions, and usually in the setting of previous, if the patient have a previous operation, history of previous operation, we should put it in the differential diagnosis. And the last cause is the internal hernia. The patient here actually have some operation before, history of operation, abdominal wall operation before, so the adhesion can be the cause of this internal hernia. And if it is the adhesion is the cause of closed loop obstruction, if it is an internal hernia, it will be the transmesenteric type. Because if we looking for the neck of the internal hernia, sorry, by following the converted mesenteric vessels, it's usually point to the site of the neck or the orifice of the internal hernia. We can clearly see this is the region of the defect, or if this is the region of the hernia orifice that is pointing along the mesenteric facial plane. So if this an internal hernia, it is usually it will be the transmesenteric type. Actually, there is here here in this case there is a sign that make us to in favor the internal hernia as an underlying etiology for the closed loop obstruction rather than the adhesion, is by looking for the superior mesenteric, the main trunk of the superior mesenteric artery and vein. If we see here, there is a right side rotation for the superior mesenteric artery and vein, and this is one of the criteria that is usually present in the transmesenteric type of internal hernia. You can see here, this is the superior mesenteric artery. Once he is arised, he is deviated to the right side, and this is not normal. And so this is one of the signs that occur with an internal hernia, transmesenteric type of internal hernia. So we in favor the diagnosis of the transmesenteric type rather than adhesion as a cause at underlying etiology for this for this closed loop obstruction. Also, we can clearly see that there is a poor enhancement and mural thickening of the involved bowel loops, and also we can see that there is a peripheral distribution for the air luculi, and this is again one of the signs of ischemic bowel, advanced ischemic bowel, which is called pneumatosis intestinalis. So in this patient, we suspect that there is a complication for the closed loop obstruction. There is a ischemic bowel and maybe areas of or signs of pneumatosis intestinalis, the small air luculi that is peripherally oriented here. That is maybe signs of the pneumatosis intestinalis. And again, the ischemic bowel is a frequent complication of the closed loop obstruction, especially the transmesenteric type of internal hernia. Is the if it is the underlying etiology, it usually associated with or complicated with ischemic bowel. We can clearly see the difference between the normal mucosal enhancement here in the proximal jejunal lobes and the lack of enhancement or poor enhancement seen at the distal iliac lobes, and signs of ischemia and even there is an misty mesentery and free fluid. All these features are keeping with ischemic bowel changes. So we wrote the report as signs of closed loop obstruction with possible signs of ischemic bowel changes and pneumatosis intestinalis. The underlying etiology is usually in favor with transmesenteric type of internal hernia rather than adhesion. Actually, the patient here is operated, and this is the bowel here that is seen entrapped in the closed loop obstruction, and we can see here this is the area of gangrene that is seen in these affected bowel loops. Sorry. That is seen in this affected bowel loop. So this is the gangrenous bowel loops here. Another picture. This is the dead or gangrenous bowel loop that is resected in the operation. Okay. Next case here will be a few cases will be usually discussing the MSK, and first case here, this is a 38 years old male who came with a history of stab wound to the root of the neck, and for suspecting a brachial plexus injury. Actually, this is MRI brachial plexus, but we will not discuss the MR brachial plexus in this case. We will discuss it separately in next session, inshallah. This is there is, because there is here no abnormality in the brachial plexus. This is the roots of the brachial plexus here, and this is in the roots in the interscalene space, and this is the trunks of the and cords of the brachial plexus in the costoclavicular and rectopectoralis minor space. There are no abnormality here in the brachial plexus, but if we see here or scroll here, we can see that there is a diffuse edema affecting the trapezius muscle. Trapezius muscle is showing diffuse edema signal affecting the trapezius muscle with no evidence of fiber disruption. The fiber here is not disrupted. Such pattern of edema signal that involving the whole length of the muscle with no fiber disruption, usually one of the signs that is of denervation injury of the muscle. So this pattern, I discussed it before. Once you see a diffuse edema involving the whole length of the muscle fiber with no fiber disruption, you should put the possibility of denervation injury. So this is a pattern of denervation injury. Usually it is not acute actually, because if we compare the girth of the two muscles, of the two trapezius muscle on the both sides, we can see there is a reduced in the girth of the right trapezius muscle as compared to the left side. So there is an some sort of subacute to chronic stage of the denervation injury. In the acute stage, the bulk remain the same, but after that it start to reduce in the muscle thickness, and at the chronic stage it will be atrophied and there is a fatty infiltration. The reason here why it is the brachial plexus is intact while the trapezius is involved, because it is supplied by the spinal accessory. The spinal accessory not a branch from the brachial plexus, it comes from the brain directly to supply the sternomastoid and the trapezius muscle. So we expect that the injury here is in the root of the neck directly affect the spinal accessory nerve and cause denervation injury. There are also another finding which is important is the disruption of this muscle. This muscle is the insertional fiber of the serratus anterior. We can see here this is an intact, but here it is not present, and this is disrupted from its insertional fibers. If we can see here, this is the serratus anterior. There is a disruption, absence of the serratus anterior. If we can see here in the axial images, this is the serratus anterior here that comes to insert into the scapula. Here this is the serratus anterior. Here there is no serratus anterior, and there is fiber disruption and replacement by fluid signal. So this is a second example for the second entity of the muscle injury, which is a direct traumatic injury to the muscle fibers itself. And as we discussed before, it usually classifies into three stages. If there is no fiber disruption, this is grade 1. If there is partial fiber disruption, this is grade 2. If there is a complete fiber disruption and avulsion, this is called grade 3. So this is from grade 2 to grade 3 injury or strain for the insertional fiber of the serratus anterior. So this interesting case because it shows the both pattern of muscle injury, the denervation injury affecting the trapezius, and also the traumatic grade 2 to 3 strain of type of injury affecting the insertional fiber of the serratus anterior. Okay, this is an MRI wrist for this patient. Patient have a chronic injury and chronic pain, in complaining of chronic pain of the wrist. In these images, we can see here that this is the triangular fibrocartilage, and this is a central component and attachment of triangular fibrocartilage usually by cartilage. So we can see that there is a high signal usually at the insertional site, radial attachment of the triangular fibrocartilage, and this is the triangular ligament attachment of the triangular fibrocartilage, which is usually two bands, the foveal insertion and the laminar insertion, and the intervening high signal, which is called a ligamentous subcarinatum. So it appears that the triangular fibrocartilage is intact, but if we scroll ventrally, we can see here that the volar radioulnar ligament is intact, and we can see the direct attachment of the volar radioulnar ligament into the radial side, in contrary to the triangular fibrocartilage. If the ligament is attached by high signal cartilage, this is triangular fibrocartilage. But once you see the ligament is attached directly, this is either one of the radioulnar ligament, either the volar or the dorsal radioulnar ligament. So this is the volar type of radioulnar ligament, and the dorsal component of the radioulnar ligament here, this is the dorsal component. We can see here this is a direct attachment in the radial aspect, but the superior aspect of the dorsal radioulnar ligament is showing ill definition. Here this is the volume images. We can clearly see here this is the dorsal radioulnar ligament, and we can see here that superior aspect of the dorsal radioulnar ligament is disrupted, just the inferior aspect, while the superior aspect is ill-defined. In the axial images, it is actually can be appreciated also. This is the sigmoid notch, and the fiber that is directed from the edge of the sigmoid notch to the styloid process, this is the radioulnar ligament, and this is ventrally, so this is the ventral radioulnar ligament, while the dorsal radioulnar ligament here is ill-defined and showing edema signal. So there is a partial fiber disruption for the ligament here, which is called dorsal radioulnar ligament. If there is an affection of either the volar or the dorsal radioulnar ligament, there is usually associated with instability of the distal radioulnar joint. So you should look for the distal radioulnar joint if it is in place or if it is subluxated. In this case, we can see if we if we draw two line parallel to the sigmoid notch. This is the one line and this is the other line. The ulnar head should be in between these two lines. Sorry, in between these two lines. So here there is some sort of dorsal subluxation of the ulnar head, and this is matching the association of the injury of the dorsal radioulnar ligament. So this is a typical example for the injury of the dorsal radioulnar ligament associated with dorsal instability of distal radioulnar joint. But it is important to say that you should comment upon the distal radioulnar joint only by this mechanism, or by this uh, relations, only if the wrist is imaged in a prone position. You should image the wrist in a prone position to say this is dislocated or subluxated, or can follow this rule in just pronated wrist. If it is supinated, this rule is not applied. So you can apply this rule and say there is a dorsal or ventral subluxation of the ulnar head only if the wrist is imaged in a prone position. If it is in a supinated position, this rule is not applied, and it can be the head can be, you can see the head is dorsally or ventrally subluxated, and this is will not be a pathological. It could be a normal, because in the rest in a supination the head can be dislocated or subluxated anteriorly and posteriorly. It is normal in a normal pattern. Here the last case here, 28 years old male patient who came with an injury to his right shoulder, and we can see here that there is a wide separation of the acromioclavicular ligament, acromioclavicular joint, and there is a disruption of the acromioclavicular ligament, the inferior and superior portion of the acromioclavicular ligament, they are disrupted. So there is an injury of the acromioclavicular joint, and it is important, as we discussed this classification of the acromioclavicular joint, is to look for the coracoclavicular ligament. The coracoclavicular ligament, they are two ligaments extending from the tip of the coracoid process to the underlying surface of the clavicle. And if we see here, there is a disruption of both ligament, the conoid and this is the trapezoid. There is a disruption of this is the remaining part of the conoid ligament. This is disrupted conoid ligament, and the trapezoid is ill-defined, and there is a surrounding by or replaced by edema signal. So there is an injury of the coracoclavicular ligament, and this is one of the important points to look for if these ligaments are intact or not, because if they are injured, as in this case, this is considered stage 3 or stage 3 or grade 3 injury of the acromioclavicular ligament, and usually this is treated surgically. If they are intact, this is either stage 1 or 2, and this is usually treated conservatively. So in any case of the acromioclavicular injury, you should look for the coracoclavicular ligament and if they are disrupted or not. In the sagittal images here, we can see the ligament also, coracoclavicular ligament, that is extending from the coracoid to the inferior surface of the clavicle. We can see here they are ill-defined, they are replaced by edema signal, and they are lax. So they are there are evident injury for the coracoclavicular ligament, and this put the patient or this injury in a grade 3 injury. If we do an X-ray for this patient, we should do a comparison study, or we should image both shoulder at the same time. You should image the right shoulder and the left shoulder at the same time. It is important because you can clearly, or you can easily compare both sides of the acromioclavicular ligament, acromioclavicular, both sides of the acromioclavicular joint, and we can clearly see there is a widening of the acromioclavicular joint here, and in relation to the other side, and we can see here there is a widening of the coracoclavicular distance in relation to this side. This indicates that there is an injury of the coracoclavicular ligament. So this is the grade 3 pattern of acromioclavicular joint injury in the X-ray and in the MRI. Thank you. This all cases in this session. I hope meet you soon, inshallah, and I hope these cases were interesting, and meet you soon, inshallah. Bye bye.